Chest pain is one of the most common health problems. The causes of chest pain ranges from serious issues like heart attack to simple anxiety. So let us see 18 causes of chest pain. The first cause of chest pain is heart attack. Patients often describe the symptoms of an acute coronary syndrome as discomfort rather than pain. The discomfort may be a pressure, heaviness, tightness, fullness, or squeezing. Ischemia is less likely if the discomfort is knife-like, sharp, pleuritic, or positional. The classic location is substernal or in the left chest, and radiation to the arm, neck, jaw, back, abdomen, or shoulders may occur. Pain that radiates to the shoulders or occurs with exertion significantly increases the relative risk for acute coronary syndrome. The second cause of chest pain is pericarditis. Chest pain that results from acute pericarditis is typically sudden in onset and occurs over the anterior chest. Unlike pain due to myocardial ischemia, chest pain due to pericarditis is most often sharp and pleuritic in nature, with exacerbation by inspiration or coughing. One of the most distinctive features is the tendency for a decrease in intensity when the patient sits up and leans forward. This position, seated, leaning forward, tends to reduce pressure on the parietal pericardium, particularly with inspiration, and may also allow for splinting of the diaphragm. Radiation of chest pain to the trapezius ridge has also been considered to be specific for pericarditis. The third cause of chest pain is aortic dissection. Typically, the pain is severe and sharp, knife-like. Pain can occur in isolation or be associated with syncope, a cerebrovascular accident, acute coronary syndrome, heart failure, or other clinical symptoms or signs. The fourth cause of chest pain is pulmonary embolism. The most common presenting symptom of pulmonary embolism is dyspnea followed by pleuritic chest pain and cough. Hemoptysis is an unusual presenting symptom. With massive pulmonary embolism, patients can present with shock, arrhythmia, or syncope. The fifth cause is pulmonary hypertension. The most common initial symptoms of pulmonary hypertension are exertional dyspnea, lethargy, and fatigue. Exertional chest pain is usually due to subendocardial hypoperfusion caused by increased RV wall stress and myocardial oxygen demand. However, it is occasionally caused by compression of the left main coronary artery by an enlarged pulmonary artery. The sixth cause of chest pain is pneumonia. Cough with or without sputum production, dyspnea, and pleuritic chest pain are among the most common symptoms associated with pneumonia. In addition, the majority of patients with pneumonia has fever, chills, fatigue, malaise, and anorexia. The seventh cause is pleuritis, which is an inflammation of the lung pleura and causes pleuritic chest pain. The eighth cause is pneumothorax. Patients present with sudden onset of dyspnea and pleuritic chest pain, usually unilateral. Hemodynamic instability suggests attention. Pneumothorax, which can be life-threatening and requires prompt transfer to the emergency department. The ninth cause of chest pain is due to gastroesophageal reflux disease, which can mimic angina pectoris and may be described as squeezing or burning located substernally. It can last minutes to hours and resolve spontaneously or with antacids. Bitter refluxate and regurgitation may be present. It may occur after meals, awaken patients from sleep, and be exacerbated by emotional stress. The 10th cause is esophageal spasm. Patients have retrosternal chest pain that often describe as squeezing retrosternal pain or spasm with associated dysphagia for solids and liquids. Patients have esophageal dysphagia characterized by difficulty swallowing several seconds after initiating a swallow and a sensation of food getting stuck at the suprasternal notch or chest. The 11th cause is Mallory-Weiss tears. Patients usually present with acute onset of gastrointestinal bleeding with hematemesis, either red blood or coffee. Ground emesis. Hematemesis may be accompanied by epigastric pain or pain in the back. Patients often have a history of non-bloody emesis, retching, or coughing prior to hematemesis. The 12th cause of chest pain is effort rupture of the esophagus, or BOERHAAVE syndrome, which is a spontaneous perforation of the esophagus that results from a sudden increase in intraesophageal pressure combined with negative intrathoracic pressure, for example, severe straining or vomiting. Patients with BOERHAAVE syndrome often present with excruciating retrosternal chest pain due to an intrathoracic esophageal perforation. 13th cause is peptic ulcer disease. Upper abdominal pain or discomfort is the most prominent symptom in patients with peptic ulcers. Radiation of pain to the back may occur, but back pain as the primary symptom is atypical. In untreated patients, pain can last a few weeks followed by symptom-free periods of weeks or months. The classic pain of duodenal ulcers occurs 2 to 5 hours after a meal when acid is secreted in the 14th secretion is maximal. The cause of chest pain is biliary diseases. One of the common biliary disorders causing pain is biliary colic, which is an intense, dull discomfort located in the right upper quadrant, epigastrium, or substernal area that may radiate to the back, particularly the right shoulder blade. The pain is often associated with diaphoresis, nausea, and vomiting. The pain has a characteristic pattern and timing for an individual patient. Eating a fatty meal is a common trigger for gallbladder contraction, and many patients report postprandial pain. 15th cause is pancreatitis. Most patients with acute pancreatitis have acute onset of persistent, severe epigastric and left upper quadrant abdominal pain. In approximately half of patients, the pain radiates to the back. The pain persists for several hours to days and may be partially relieved by sitting up or bending forward, and most patients have associated nausea and vomiting, which may persist for several hours. 16th cause is costochondritis. Majority of patients with musculoskeletal chest wall syndromes have a more diffuse in which multiple areas of tenderness are found that reproduce the described pain. The upper costal cartilages at the costochondral or costosternal junctions are most frequently involved. The areas of tenderness are not accompanied by heat, erythema, or localized swelling. The 17th cause is herpes zoster. Pain is the most common symptom of herpes zoster. Most patients describe a deep, burning, throbbing, or stabbing sensation. Majority of patients have prodromal pain that precedes the rash in the affected dermatome. Prodromal pain may be constant or intermittent and typically precedes the rash by 2 to 3 days. 18th cause is anxiety. Patients with anxiety has tightness, dyspnea, palpitations, other somatic symptoms.